Thank you for the opportunity to speak today. But before I begin, I'd like to acknowledge that we are meeting here on Aboriginal lands that have never been ceded and never will be ceded. We are 65,000 years strong, and we will continue to be strong and thrive. I'd like to pay my respect to all Aboriginal elders past, present and emerging, and those Aboriginal and Torres Strait Islander people that are in the audience today, and in particular my good friend Alex. We're at a critical moment in healthcare where genomics is transforming how we diagnose, treat and prevent disease. But we must ask ourselves, are we ensuring that this transformation benefits everyone equally? I am Jim O'Shea. I am the COO of VACCHO, the peak representative body of 33 Aboriginal community-controlled health organisations here and across Victoria. Our work focuses on ensuring Aboriginal health and wellbeing services can provide culturally safe, high-quality care, and right now, genomics is critical in that space where equity is at risk. So why is genomics relevant to Aboriginal health? Genomics has the potential to improve early diagnosis, treatment and prevention of disease. Yet Aboriginal and Torres Strait Islander people face systemic barriers to accessing genomic care. Our communities experience a higher burden of chronic disease, but without equitable access to genomic services, opportunities for improved health and outcome are being and will continue to be lost. VACCHO, alongside Melbourne Genomics, WeHi, the Kids Institute and the Align Network have been working together to address these barriers through our Indigenous Genomics Health Equity Project. Today I want to share some insights into that work and the insights that must inform how genomics care evolves in Victoria. There are key barriers to genomic care for Aboriginal and Torres Strait Islander people living here in Victoria. Our project has identified several critical gaps. Firstly, limited genomic services in ACOs. Many ACOs have little access to genomic care, often due to funding constraints, workforce shortages, and a lack of awareness about genomic testing options. Yet there is a clear demand. ACOs do want to integrate genomic services to assist rare diseases, hereditary conditions and high-risk family diagnosis. Knowledge gaps amongst health providers. Many Aboriginal health workers and clinicians report uncertainty about available genomic tests, the referral pathways and funding options for them. One GP shared, "We have families who could benefit from genomics. One family has 10 children and only 2 have not had heart attacks. We know that there are missed opportunities for genomic referrals." Cost and financial barriers. Many Aboriginal patients can't afford genomic testing, and some ACOs hesitate to offer Medicare-funded services due to the uncertainty about eligibility criteria. One ACO bluntly stated, "The cost of genomics is prohibitive for our community, so we just don't do it." Geographic and logistical challenges, and believe that these do exist in Victoria. Non-metro communities struggle to access genomic services, often due to travel costs, lack of local providers, inflexible service models. Therefore, patients outside metro areas face additional challenges in accessing that care. Although ACOs sometimes can provide transport and accommodation, covering these costs constrains their budgets. ACCOs have requested that mainstream providers look to internal policies on alternate options that can support patients. For example, Aboriginal health providers have shared with us that telehealth appointments should be offered as routine for remote areas where appropriate and where they currently are not. Fragmented care between mainstream providers and ACCOs. Many Aboriginal patients prefer to receive care within their ACCO due to experiences of racism and culturally unsafe treatment in mainstream services. Yet when referrals are made, ACCOs are often left out of the care process, leading to poor follow-up and subsequent disengagement. One doctor in Aboriginal health noted, "We don't receive wraparound services from external providers. They call the patient once, and if they don't get through, that's often the end of it. They don't understand the complexities of community, of people changing numbers, of kinship and cultural obligations, and of low income needs. We would like to be included in caring for our community, but often don't get the opportunity to be involved." Historical trauma and data sovereignty concerns. Historical trauma adds complexity to discussions around genomic data and consent, and the impact on stolen generation survivors are often heightened. For those with incomplete family histories, identifying genomics risk is even more complex and often locks them out of funding. Many patients have had poor experiences with healthcare institutions that involved unethical medical practices, resulting in ongoing healthcare trauma. As a result, culture care must be considered as an essential part of medical care. Lack of cultural safety. As reported by our ACCOs, many patients prefer their local ACCO because they have experienced racism or culturally insensitive care in mainstream health clinics. Instances of stereotyping patients' ability to understand, assumptions about the ability of Aboriginal patients to engage in follow-up care, offering diminished options due to assumptions of affordability, and dismissive attitudes have made some patients reluctant to be referred to external services. As one ACCO stated, genomics is not culturally safe in the mainstream system, but the concept of genomics is safe. Another member shared, "We don't actually know how safe that clinician is that you're referring to. It's really a gamble." Many individuals do not receive the culturally appropriate care they need, which significantly hinders their ability to access and benefit from proper health care. In many cases, family involvement in decision making, as we've heard a little bit earlier, is a crucial cultural practice that can conflict with healthcare accessibility when services are located far away from home. Many Aboriginal families require multiple people to be involved in decision making, as kinship structures can differ from white Western family units. As one ACCO stated, mainstream healthcare providers may not fully grasp the Aboriginal community's unique needs. Another ACCO mentioned, a lot of the big hospitals do have Aboriginal liaison officers. We know they can have amazing resources, but they need guidance and support to facilitate that. It's about encapsulating the whole experience to make it safe for Aboriginal patients from start to finish, from entry to exit. So what does need to change? The solution is culturally safe genomic care that integrates Indigenous perspectives, workforce development and systemic reform. Cultural safety is not one-off training. It's not a compliance tick box. It's a structural change that must be embedded in genomic healthcare delivery. That's why VACCHO has developed a culturally safe accreditation system for mainstream health services, which will ensure that genomic care is delivered in a way that respects and upholds Aboriginal and Torres Strait Island values, kinship structures and self-determination. This includes 8 standards which have been registered with the ACCC and IP Australia, and we are currently trialling that accreditation with 2 metropolitan hospitals and 1 regional hospital. We also need a greater investment in training and support for VACCHO clinicians and staff to help build genomic literacy and capacity in Aboriginal health. Our call to action: what can you do? As leaders in healthcare and research, you have the power to drive meaningful change. I challenge you to ask yourself, can you confidently say your organisation provides culturally safe genomic care? Are Indigenous voices shaping your genomic healthcare policies and practices? How are you ensuring genomic services are equitable and accessible to Aboriginal and Torres Strait Islander patients? To move forward, we need funding for dedicated roles within Aboriginal health organisations to integrate genomic healthcare. We need to ensure Aboriginal-led governance in genomic research and service design. Nothing about us without us. Expand funding models to support genomic care within ACCOs, reducing reliance on out-of-pocket costs and mainstream providers. My final takeaway: genomic offers incredible potential, but only if it is accessible, culturally safe, and designed with Aboriginal and Torres Strait Islander leadership at the forefront. It's not just about providing care, it's about building trust, addressing historical harm, and ensuring equity in the future of precision medicine. The responsibility does not rest solely on Aboriginal communities and health. It requires mainstream health leaders, researchers and policy makers to step up. The time to act is now. Thank you.
Wow. Well, thank you very much for the chance to speak today. If you want to know what to do about equity, just do that. Thanks, Jim and the team, for putting that wonderful work together. My name's Alex Brown. I'm from the Yuin Nation on the south coast of New South Wales. But I'd just like to pay my respect to the traditional owners of the country that we're meeting on today. This will be a little bit of equity speed dating. We've got about 12 minutes or so to get through this, so I'll start by just saying, how are you doing? No, that's pretty creepy. My apologies. So where do we start? Obviously, the very practical end of the conversation here was beautifully articulated in the last presentation. I mean, some spectacular outline of, I think, what everyone should expect from genetic health services, whether you're Aboriginal or Torres Strait Islander or not. Currently, state of play in genomics is really problematic for Indigenous people. We're not included in the game. There's no brown people in the databases on which most of the precision medicine tools that are used to improve the health and lives of families and communities. They're not built to understand our reality. As a consequence, they miss the mark. But the challenge is most people think that we can just chuck a few brown folk into the work that we do. But that misses some very salient and important points. This is data on the uniqueness of Indigenous Australians from a genomics perspective. And although that slide may be a little bit complicated, what it tells us is two fundamental things. One, Aboriginal and Torres Strait Islander people are unique and not the same as European populations. In fact, from a genomic perspective, about 25% of our genetic architecture, our variation, is different from all other population groups so far. What it also shows is we are unique between communities, well understood and well known amongst Indigenous peoples. We are heterogeneous, we are different, we have our own uniqueness, and this story is shared in our genetic architecture. We have other challenges, some of which were just mentioned by Jim, around whether or not Indigenous people will choose to be involved in the genomics agenda, this future of healthcare that we're all invested in. Well, the challenge is there's lots of things for us to work through. Communities aren't sure whether or not they're going to trust us in this work, and rightly so. Science hasn't done a particularly good job of looking after Indigenous people's interests over the last 250 years. In fact, it was weaponised against us. It was a tool of oppression, of colonisation, to separate those who were in power with those who they wanted to take land and culture from. There are concerns with who's in control of the agenda here. It's beyond an Indigenous data sovereignty agenda, although that's an important component of that story. It's who's making all these decisions and under what circumstances will we ever be given a chance to have our hands on the steering wheel. It is about data access. Who's got access to it? What are they going to do with it? Are they going to use it against us to further and again weaponise science and information against Indigenous interests? Are they going to steal stuff? Are we going to be exploited? Is this the new biopiracy, just focused on a different target? And more importantly, is it going to deliver benefits to us, to our kids, to our next generation? Or is it just a whole bunch of stuff we can do because we can? Unfortunately, that's nowhere near enough for Indigenous interests. And the reality is inclusion and having a few brown folk involved in some stuff is not equity. Now, where do we start with a push for an equity agenda within genomics? Well, it's clearly been articulated the world over that equity is an important foundation principle now in this next generation of genomics. I would argue that it should have been involved right from the start. And in fact, the birth of Indigenous data sovereignty as a movement came about because of the rejection of hearing Indigenous people's voices in the Human Genome Project. But it's clearly now identified within all of the architecture of contemporary genomics efforts and research that equity matters. But the question is it a complete or a comprehensive approach to equity as we require? Why did we start in genomics if I've got all of these problems? Well, I've got lots of problems. They're not just in relation to equity in genomics. We started work in South Australia with Aboriginal communities to resolve some enormously challenging questions, and it related to type 2 diabetes. So the community asked there, can genomics be used as a tool to understand the burden of disease that we face in our communities? Can it contend with or try to unpack the reality around why we tend to get type 2 diabetes earlier? The early onset is very, very particular feature of our phenotype. Why do we have such aggressive complications? Why do we end up on dialysis in our 30s and 40s if we have diabetes onset early? Why do we have strokes and heart disease at 5 and 6 times the rates we see in other communities, particularly in the context of diabetes? Can we better predict who's going to have trouble? Can we build better healthcare systems that genomics can inform. All questions that we thought were worth a look. But we contend with a couple of fundamental questions, not just the concerns that communities identified around the precision medicine entry point. We have questions to contend with about whether or not genomics can be used to reduce health inequalities, not just can we make sure that Aboriginal and Torres Strait Islander people can get some, please. And the question is, how do we shift the lens from the inclusion agenda to a truly equitable and equity-focused agenda? We've got questions. Will it deliver the outcomes that we desire as Indigenous peoples? Can we afford it? Should we afford it? Should we be spending money on the education and healthful nutrition of our children and not spending money on genomics? What are the ethical, legal, social and cultural implications that we have to contend with? Who's in control? Can we access stuff if we identify a genomic target? Can we get the stuff that your genetic signature would suggest that you should? Do we have the right models of care? Have we trained the right workforce? Is there enough of them? My view, in the context of genetic counsellors, we need at least another 1,000 in this country, probably more. And can genomics be shifted, not just to get access for everyone, but can it be used to reduce inequalities? Can we shift the lens of genomics to a purpose beyond, hey, let's all get some, thanks very much? The other challenge we face is that equity relies on the goodwill of the system, which has been a part of the creation of inequalities in the first place. So we beg, particularly those of us who are outside the healthcare system, who don't have the keys to unlock the doors, we beg for a chance for equity to reign free, and it's not an easy task. Thus has been a very strong push for movement beyond an equity agenda to one of sovereignty, of Indigenous people themselves defining their own future, making their own decisions and constructing the right way forward for all. So why would we even grapple or consider this agenda? Well, you guys are all witnessing, whether you know it or not, the birth of Indigenous genomics as a global phenomenon. A network of Indigenous people the world over coming together to support each other to find the right way forward, to build the next generation, and to make sure that genomics is done in an ethically and culturally sensitive and appropriate way. And the reality is, Indigenous genomics is not just getting some genomics to Indigenous people. It is, in its own right, a new way of considering the way in which genomics can be applied, the way it can be built, the way it can be held to account, and the way in which it can be driven by Indigenous people for the benefit of all. And that's where we're trying to build our way forward here in Australia by the establishment of the Australian Alliance for Indigenous Genomics. Funded by MRFF, a very strong focus on firstly building a network, which we've been able to do fairly successfully. Our job is to enhance Indigenous people's involvement and control and say and agency in Indigenous genomics efforts. Our job is to identify the key policy matters and respond to them, either by bringing together the best available evidence or building it ourselves, as we often have to do when it comes to matters of Indigenous health. Our job is to build the next generation of Indigenous scientists, Indigenous genomicists, Indigenous genetic counsellors, Indigenous practitioners who understand what a genomics-infused healthcare system of the future is going to look like, needs to look like, and that we will be the stewards of. Our job is to ensure that genomics isn't just about getting some, that it delivers a benefit. And what that looks like for us needs to be defined and prosecuted. So what does equity in genomics look like, given that I'd like to contend, is more than just an inclusion agenda? It is about establishing the right principles on which genomics is built for Indigenous people, by Indigenous people, engaged with the broader ecosystem for genomics delivery into healthcare. It'll be an empowerment agenda. It'll be built on the right principles, founded in respect. It will have to deliver within a cultural context. It will have to be about delivering benefit. Having some more of stuff is not enough. It'll need foundations that will ensure dedicated resource, the building of the right workforce, the education of the existing workforce, the right infrastructure, particularly around data, data systems, data sciences, and data sovereignty. It'll be about the right policy, legislative frameworks to protect the rights and interests of Indigenous people, and it will be about access. But an equity agenda is always about access according to a person's level of need. It will bend the wheel of genomics, not just to deliver stuff, but to actually actively seek to answer the fundamental questions we have of the conditions that drive inequity in the first place. And that's why our interest in chronic diseases, not because it's the easiest, it's probably the messiest, but because it drives 80% of the life expectancy gap for Indigenous Australians. It will be about understanding our own uniqueness and what that means in terms of health and well-being. It'll be about prevention. And largely, there's efforts that we must contend with around implementation. How do you do it? For whom? Under what circumstances? Whose heads do you need to knock together? Whose butts do you need to kiss? Whose hands do you need to squeeze overly hard in a handshake while looking them in the eye and pretending you're not trying to do the crusher on them? How do you hold a system to account? How do you change the way in which we think through what a healthcare system of the future needs to look like? So while we traverse our initial conversations about the importance of inclusion, let's not forget how critical an equity lens has to be within this. But ultimately, look out, Indigenous people want control of their own destiny in genomics. It is a sovereignty agenda. We can't do it alone. But if you're not going to help us, just get out of the way and we'll get on with it. Thank you.